continue where Dr. Chada left off, and about how we use music therapy as an integrative strategy in working with Dr. Chada's breast care patients, breast cancer patients. And just a quick overview about the merging of a dedicated music psychotherapy program with allopathic medicine. We're going to be speaking briefly about music psychotherapy, strategies for individualized and personalized care, as Dr. Chada mentioned, that contribute to best practice, maximize patient comfort and quality of life. And lastly, I'm going to be speaking a little bit about emotional distress and its flow into trauma and how it results at times in as post-traumatic stress syndrome. So first off, a little bit about music psychotherapy. Closer to the mic? Yes. So we have Sigmund. This is where Sigmund met Ludwig. And what we end up with is a psychology construct. And the model that we use here at Beth Israel is an eclectic model. There are elements of psychodynamics. I would say that probably we're mostly humanistic in our slant, but you really can't escape Freud. You can dance around him, but he's always there, I think. Looking a bit at how we use music as a therapeutic tool, and as I'm sure everyone in this room knows, music is a complex phenomenon. And music elicits emotions, it modulates affect, it regulates the autonomic nervous system function, and affects hormonal and immune systems. This is validated by the literature. Emotions are a particularly important part of the work that we're doing with music therapy in radiation oncology. I'll get deeper into that as we go along. So music perception, once again, is quite a complex phenomenon involving auditory analysis, auditory memory, auditory scene analysis, processing of interval relationships, musical syntax and semantics, and internal representations of actions. So, clinical properties of music, or this could be a way of starting to look at it, is that music is by nature metaphoric. Metaphors elicit images and associations. We think, it could be said, we think in words and images. Images can be created through music, thus enhancing the direction of a therapeutic process. Music can very much be the gateway into psyche and so on. So, music can affect and modulate emotion. We don't actually use headphones with babies, but I really like the change in the expression. This next slide is about something that in the presentations I think I've heard almost everyone talk about at some point, even Dr. Strada, which is this theory of entrainment. And entrainment is one way to explain it. Physiological phenomena characterized by a calibration, right? And if we're looking at music, what gets calibrated are the elements of music itself and the human organism, or human or animal. There is some research on animal response. There's a really great study on a cockatoo that some of you may have seen. I see nobody has seen that. Okay, so this is a little demonstration of, on a completely physiological level, of what entrainment might look like. There's no sound on this, so it's just going to be visual. Randomly starting off the metronomes. And as if by magic. Yeah, pretty incredible. Okay, the same sort of process, or something analogous to that process, happens when we use music. We can all think of probably the example that comes to mind first about how we entrain with music is if we play music with a good beat to it. What is usually our immediate response to that? Yeah, we move. So we're entraining. Entrainment happens on a much deeper and complex level of the human organs. We're going to explore a little bit about emotional response to music and the sort of images and metaphors that might come to mind as we listen to different pieces of music. So I'm going to play a couple of snippets of pieces and just ask you to see, maybe monitor, see what ideas or what images might come to mind, if any. If you're my age, it was probably something like this. And the next. Very different type of tension in this music. Yes. And now, perhaps a different type of imagery. Okay. Very different response than to those two first pieces. And now, something I think you all might enjoy. Every single time. My favorite image. Probably what most of you are thinking about. So what just happened in that process of listening to music was pretty much a systems response. So that's not just an auditory process, not just an emotional process, but actually cognitive and executive function, emotional limbic function, autonomic nervous system function, and physical motor actions and reactions. When that last piece came on, everybody sort of did this. Use the microphone. Thank you. Okay. This is at the Louis Armstrong Center for Music and Medicine. This is our theoretical orientation. We are music psychotherapy oriented, and as we understand it, music is used within a context, and that context is a professional relationship between patient and therapist. We also follow a wellness model. That is looking at how the person was when they were well, not as they are when we usually see them, which is ill. We use predominantly live music, although in certain situations we do use pre-recorded music. I'll be talking about one of those situations in radiation oncology. And we are very well attuned to multicultural perspectives. New York is a melting pot, to say the least. We take a holistic view of the person, looking at physical, emotional, cognitive, developmental, social, and spiritual. And we are also finely attuned to assessing and working with trauma in our patients. So moving on to what we do in radiation oncology with breast cancer patients. And we provide individual music psychotherapy sessions in a couple of different contexts. The first context that we've been talking about quite a bit, so I'll just go over that quickly, is simulation. That process has been described by a couple of different presenters at this point, so I won't continue with that. But the reason that we do place so much importance on simulation itself is that we have an idea that if this is the patient's first contact with treatment, it is their first experience in the radiation therapy department, that if we can somehow modulate that experience and have that experience feel something that is safer for the patient, that we can perhaps modulate their entire experience with treatment. We do use pre-recorded patient-preferred music in radiation therapy, in treatment itself. I'll be speaking more about that a little later. We also provide procedural support for hydrations, venipuncture, and blood draws. Once again, and this is perhaps a common experience for many patients in radiation oncology, are phobic reactions and claustrophobic events during simulation, especially, but also during radiation therapy itself. So on occasion, while I will not be in the room with the patient during radiation therapy, I will be with the patient while they're getting set up for radiation therapy if they are having severe phobic reactions to something. Perhaps the positioning device that seems to occur more with head and neck patients than with other populations. And also, last but not least, environmental music therapy, and I will speak a little bit about that later also. So areas of music therapy intervention, we work with emotional trauma, state anxiety, depression, mood disorders, emotional needs, spiritual needs, enhancing quality of life, pain management, and we do have a number of, I was going to say protocols, but I think I'll just say specific interventions that we do use for pain management with patients. We also look at temporal distortion and tension in waiting areas, and work with many patients on their feelings of loss, which can be physical, psychosocial, or existential. A little bit about emotional trauma. This is something that really grabbed my attention. 23%, this is a recent study, 23% of women who are newly diagnosed with breast cancer have post-traumatic stress disorder symptoms. And this is especially prevalent in African American and Asian women, as well as for younger women. So how we address emotional trauma, our approach and our postulates are a combination of a technique and a philosophy called somatic experiencing, which is Peter Levine's baby, and also we take into account Stephen Porsche's polyvagal theory, and we have a number of constructs that we apply to music psychotherapy intervention for addressing and processing trauma and PTSD. So the risk indicators for PTSD seem to be, with this population, prior trauma, hyperarousal, prior acute stress disorder, and a variety of personal and environmental factors, or what we call a lack of post-traumatic resources, and there can be many of these. Also, very interestingly, a risk factor or indicator is being female. So, state anxiety. I've heard many, or let's put it this way, quite a few presenters talk about anxiety and stress. And state anxiety seems to be something that is ever present in cancer treatment. It is sometimes acute and sometimes not. Sometimes it is low level, but it seems to be sort of a prevalent condition for many patients in radiation oncology. So anxiety is felt. It is a sensation. It's not an idea. It is the somatization of a diffuse, unpleasant, vague sense of apprehension, or painful or apprehensive uneasiness of mind over an impending or anticipated ill. And in a wonderful grand rounds that took place last year, Dr. Schmidt, who presented, stated this very simply: anxiety exacerbates pain. I think that's a huge statement. And a plausible line of thought is that the hypervigilance that accompanies anxiety may increase susceptibility to appraise nociception as being more acute pain than it would be identified in low anxiety states. So, more relaxed patients perhaps have a lower pain perception. I wanted to provide an experiential on environmental music therapy. I won't be doing that, but I will be providing an experiential on a protocolized intervention that we use for simulation. So, environmental music therapy. We noticed that in the hospital, in general, that there was something that seemed prevalent. Actually, two things. One, that the noise level in hospitals in general, and perhaps even Beth as well, that the noise base was actually quite high. And the other thing is that it seemed that many patients in their experience in the hospital perceive the hospital as being sort of a hostile place. I think that's a fair assumption. So we were wondering what we might possibly be able to do with music on a generalized, in a generalized way to address those two issues. And the idea that Dr. Joanne Lowy developed was this idea of environmental music therapy. So one definition of it, and we could provide many, but one would be that it's the intentional use of live music and sound to modulate the soundscape of an area or space, and that it has the capacity to transform an environment. Okay, I think that that's a huge statement. If we're looking at trying to make a hospital experience seem less hostile and a safer, more agreeable place to stay, and we can do that with music on a generalized scale, I think that's quite something. And the way one way that this can be approached is using the idea of a movie soundtrack. So if we think about what a movie soundtrack does, there's this little thing that I do with an exercise that I do with some of my students, and I have some movies that I've been able to take the soundtrack out of, not the voice soundtrack, but the music soundtrack. So, you know, typically you see this really scary horror movie, dark hallway, right? And there's this music that builds and builds and builds, and at the end there's a screech, and that's when the knife comes out. Right? Okay. You take away the music, and you watch the same sequence, and what you see is a woman walking down a dimly lit hallway and opening a door, and absolutely nothing happens. And there's no fear response without the musical cues and clues that are telling us what we need to feel. Same thing, romantic movie, right? Lush violins, two lovers meet, they embrace, and we have this outpouring of romantic feelings. You take away the music, and what you see are two actors that look sort of uncomfortable with their close physical proximity. Okay, so using this idea of a soundtrack, we listen to the sounds of the environmental sounds here, the sounds that are present. That includes conversations, that includes staff conversations, ambient noise, and through improvisation, trying to incorporate those elements in the music, we try and create a soundtrack. So the soundtrack, we have to come up with an idea. What would we like the people listening to this to feel? What sort of emotional response are we looking for? And that's part of the process. So in environmental music therapy, the therapist can play with as opposed to play to the environment. That's incorporating what the therapist sees and hears into the music that he or she produces. We're not trying to mask sounds. There are a number of cases where that's actually illegal to try and do in a hospital, such as on any units that have monitors and monitor alarms. The monitor alarm has a function, and you are not allowed to lower the volume or try and mask that sound or disguise it in any way. So what we try and do is incorporate the sounds of the monitors into the soundscape. Hospital staff can still hear the monitors going off, they hear the alarm, but often their response to the alarm appears to be different and perhaps not as stressful. So the idea is to try and form a non-noxious soundscape and provide for more positive mood states. Dr. Chadha mentioned one of our studies that we're doing in radiation oncology. This is actually the second one, and this is on environmental music therapy. And what we're looking at are two different things: the levels of state anxiety in waiting areas and the perception of waiting time. And this whole idea of the perception of waiting time has to do with patient satisfaction, also has to do with quality of services, and once again for patients feeling safe in a place. And this all came out of sort of an offhand observation, what started as an offhand observation. And often I'm by the receptionist's desk there, and I see patients as they come in, pretty much have a good idea of exactly what time they arrive. And so they sit down and they wait for treatment. Sometimes waiting times can be quite long. And what I observed was that patients that had been waiting for more than a half hour, but less than an hour and a half, pretty much consistently rated their waiting time as 3 hours. Now I thought, all right, nobody's going to say, if they're waiting for an hour and a half, they're not going to say, I'm waiting for 5 minutes and I'm really sick of it, when can I get treated? But what seemed really strange was that it seemed to be more than a coincidence that there was this idea of 3 hours. So we decided to see if there was something that we could do with music therapy to, once again, affect perception of what was going on in the environment. And so what this study is looking at is how does environmental music therapy affect patients' perception of time. And, well, this goes without saying. The waiting room is a petri dish for state anxiety. Negative anticipation and anxiety appear to exacerbate temporal distortion. So the idea is that if patients are anxious and they're waiting, that's going to contribute to the waiting time seeming longer. The longer waiting time is going to feed back into the anxiety. Okay. I'm going to speak a little bit again about simulation once again because we think it is so important in the process. And so perhaps the ideas that patients come in with is a great deal of uncertainty, and they're certainly fragile. There's a considerable risk for potential medical-related emotional trauma. We believe that music therapy can be prophylactic treatment for emotional trauma, and this is based on a postulate that changing the initial preparation for radiation therapy will alter the patient's entire experience in radiation treatment. The radiation therapist that I work with very closely, Donald Hilton, who was one of our panelists yesterday, we worked very closely together, and he gave me very generously lots of feedback on what our combined interaction with patients was like. And one of the things that he brought up is there's a need for patients to be calm and focused for simulation, because what simulation is all about is accuracy. So if you have a very anxious patient, there's probably going to be a lot more moving going on, and that the actual images could not be as accurate as they would be if the patient were more relaxed and still. He also mentioned that a tense patient or an anxious patient has very tense muscles, and that at some point, if they do relax, there's been a huge change in that imaging process. So what he's saying is it's better, it's best if they're relaxed when they come in first and not relaxed during the simulation procedure itself. Okay. So when I work one-on-one with patients before simulation, one of the things that we talk about are patients' associations and images with the idea of simulation and treatment. And in breast cancer patients, these are the four most common. Oops. Okay. Being restrained. There is a reason for this. A number of patients have said when they're being simulated in prone position, where their breasts are hanging down, they're not actually on the table, that they feel like a cow. That's actually quite common. Being a little bit overwhelmed, feeling threatened, and being somehow frozen in time during the process. So for simulation, we have a two-part protocolized intervention, pre-simulation, that we provide. It is music psychotherapy with live music and simultaneous verbal processing. Psychoeducation on relaxation techniques, which can be used during simulation and during radiation therapy itself. So I'm going to provide an experiential of this. I'd like to explain a little bit about the intervention itself beforehand. So the intervention has live music. There is an induction. There's an induction to altered state. There are three separate processes that I take the patient through. That while they're going through each process, they are being psychoeducated on a skill or a tool that they can use later on in simulation or in radiation therapy itself. And I also feel that aside from the psychoeducation and the tools, that when we finish the intervention and all of that is reinforced about that they've learned tools, that's also a way of empowering the patient so that perhaps they're no longer a passive spectator, but they're actually able to be proactive during treatment itself. And during simulation, while I'm not in the treatment room itself, we're using what we're calling prescribed pre-recorded music. And we're calling it prescribed pre-recorded music because it has the music programs that we create on the fly for each patient have specific individualized clinical objectives. And usually, for most patients, what we're looking for is reducing state anxiety, structuring time for them, and reducing traumatic triggers. So the music itself, during assessment, a patient will say that they like perhaps 2 or 3 different types of music, or instruments, or specific periods of classical music, or specific periods of jazz, or pop, or rock music. And I have a pretty big database of music to choose from. And a great deal of that, or let's say I'll be more realistic, part of that is music that I've already analyzed. And it's been analyzed according to a 17-point algorithm that looks at metaphoric content, descriptors, as well as the actual musical elements itself of the piece. So with this analyzed music, we're looking to create a contour through a listening experience of, in this case and in many cases, of provoking a relaxation response. And the way we're doing that is within a number of different pieces of music, or sometimes within the same piece of music, we're looking at something that starts off at the patient's level of activation and probably gets a little bit more activated because new experience, we get a little bit more activated. And then the music will shift and change, the musical elements change, and this music will become less active, less active, less active, then perhaps go back up again, and then down to provoke the deepest relaxation response we can. Thank you. Okay. These are quotes from Donald Hilton's, and I think, Joanne, I might just skip to the experiential. Okay, so